Hi, Dr. Ussher.
Hi, Daryl.
Hi, thanks for being part of our conference. You're in Australia, I'm in New York. It's morning for you, it's evening for me, but it's the time to talk about prostate cancer and our LGBT community, no matter what time anybody's watching this. So can you tell our audience what you do and where you do it?
So I'm a professor of women's health psychology at Western Sydney University, and I've been working in the field of psycho-oncology for over 20 years now, which has expanded my interest from women's health to look across genders in terms of experiences of cancer and cancer care, and more recently to look specifically at the LGBTQI population. So I've been doing research, a number of studies looking specifically at gay men and prostate cancer and their experiences of cancer survivorship and care, and also more recently looking at across the LGBTQI population, so looking at people with a range of cancer types, looking across gender, across sexuality, and including trans and gender diverse and also intersex people.
Cool. And what year do you think was your first investigation around gay and bisexual men and prostate cancer?
Specifically on the gay and bisexual men and prostate cancer, most of the research that I've published in that was published in the sort of mid 2000s. And that was a study that we did funded by the Prostate Cancer Foundation of Australia. And we had done some research previously, which was looking at sexuality across both heterosexual and gay, bisexual and lesbian individuals. So we had small samples of queer people in those studies, which were in earlier than that, in the the late 90s and early 2000s. But they were very small samples. So the substantive work that I've done has been really probably in the last 10 to 15 years.
Yeah, and so you are indeed a pioneer of our field, and that's really cool. Let's start with what you know, what you've learned today, and work our way backwards. And the goal of today's presentation is to just harvest lots of useful hints and understandings from Dr. Ussher for the average gay man or bisexual man diagnosed with prostate cancer, and how you could use that. Uh, what recently have you learned as far as like being able to predict outcomes and quality of life?
Well, I think there's really quite established knowledge now that gay and bisexual men with prostate cancer, as well as other LGBTQI people with cancer, are at higher risk of psychological distress than heterosexual and cisgender people with cancer. So, for example, the recent study that we've completed, that I'm actually literally writing up at the moment, where we had 430 people who identified as LGBTQI who had cancer, what we found is that they had significantly higher distress compared to the general cancer population. And they also had significantly lower quality of life. Now, that could sound like a really depressing message, because it could suggest everybody who's LGBTQI has high distress. And that's not the case, because some people didn't. Some people reported low levels of distress, in fact, lower than you'd see in the general population. So within our sample, we found some people were at higher risk of distress. They were younger people, so it's often called AYAs, adolescents and young adults. And by young adult, we're actually meaning anybody who's younger than 40. So in cancer, what's seen as young, particularly in the American context, is defined as 39 and younger, which is maybe reassuring for some people who don't feel particularly young, but are in that age group. So that the adolescents and young adults did report higher distress. And we also found that people who identified as transgender or non-binary reported higher distress than the cisgender people within our study. So there are some people that are really at much more risk of distress than others, and also people who had lower social support, and people who experience more what we describe as minority stress in their lives. So we've looked in this study at some of the factors that might predict why a person who's gay or bisexual or trans with prostate cancer might, or with any other form of cancer indeed, might be distressed. And what we found is that people who experience what's described as high minority stress in their lives are much more likely to be distressed when they have cancer. And what minority stress is, it's experiences of discrimination in life because of being LGBTQI. It's feeling excluded. It's feeling that sometimes it's experience of violence, experience of harassment, of hectoring, just in daily life. So we asked people in our study, our most recent study, had they experienced discrimination? And we found that the majority of people had experienced discrimination in their lives at some point because of being LGBTQI. And we also looked at this in cancer care, and we found that there was a significant relationship between being discriminated against in cancer care and being distressed.
So lay people who don't sit around investigating things, and there are a couple of thousand sitting virtually behind me, are wondering, well, okay, I get it. You were researching slash investigating. The terms are moderately interchangeable. The idea, cancer, uh, but wouldn't that level of distress and disparity be true for obesity or gout or COVID or any other kind of disease state?
Yeah, I think that's a really good point. And actually, if you look at LGBTQI people outside of the context of cancer, they report higher distress than heterosexual and cisgender people anyway. And in fact, the argument for why that's so is because of minority stress. So what we can say is that those factors that might cause somebody to have a higher rate of depression, a higher rate of anxiety, be more likely to have suicidal ideation, which is what the mental health research in the general LGBTQI population looks at, we find higher rates of those variables in the LGBTQI population, and that's attributed to minority stress, to the fact of being discriminated against, and also to what's often described as internalized homophobia or internalized transphobia, where you've been taught from a child that your sexual identity or your gender identity is wrong, it's sinful, in some contexts it's criminal, and that you internalize that, and then you feel bad about yourself, you feel bad about who you are as a lesbian, as a gay man, as a trans person. So that's also part of minority stress, and also concealing our identities as an LGBTQI person can also be seen as part of minority stress. So if you're not out in your life because you're afraid of being discriminated against or because you feel ashamed. So that sort of combination of factors is a sort of associated with distress. And yes, you're right. If we were talking to LGBTQI people with gout or with obesity or with heart disease, we might find those same associations. It's interesting, actually, there's very little research on that in other forms of chronic illness. And actually cancer is an area where researchers are really leading the way in terms of saying we really need to look at these health disparities that are being identified and actually need to look at the specific needs of LGBTQI people with cancer. And I think one of the things that I can say what is specific to a cancer context is it's an illness that many people live with for a very long time. You know, people who've had a cancer diagnosis, many of them actually do recover or they do go into remission. They do actually live with having had a cancer diagnosis for a long time. And what we know is those early experiences with healthcare professionals, the things that happen at diagnosis, the way you're treated, whether you're able to have your identity as a gay man with prostate cancer or bisexual man with prostate cancer actually acknowledged by the healthcare practitioners actually has a real impact on how you are in terms of yourself, your well-being, whether your partner is allowed to be included in your care. It has an impact on your satisfaction with care, and it actually potentially has an impact on your long-term coping with the changes of cancer, and particularly the physical changes around sexuality. And that's one of the areas that we looked at very specifically in our research that focused on gay men and bisexual men with prostate cancer.
So let's talk about that, because that really sort of is the pipeline to disparity and distress for prostate cancer, for heterosexual men and gay men and such. But gay men have an added value to sexual opportunity, sexual relationships, sexual behavior. I hate the word behavior, but I struggle for better words. But the idea of just being with another man in an intimate way is different for men than it is for a man and a woman in society in 2022 and probably through 2032, and God forbid longer than that. The idea of impotence and urinary incontinence impeding sexual enjoyment and behaviors the way you might have had prior to treatment is a critical thing. What have you learned around that?
Well, can I talk a little bit about what we learned about sexuality first, or do you want me to focus
Sure.
specifically on, yeah. So I've done a lot of research on sex and cancer. I've been doing that for, 20, 25 years now. And what we know is that cancer has a really big impact on people's sexual well-being. And that's quite established in terms of psycho-oncology. What hasn't been looked at until relatively recently is the differences for, and I'll talk specifically about gay and bisexual men here. They've been described as an invisible diversity, a completely marginalized population in mainstream cancer research that's looked at sexuality. So there's a number of studies now, the work that we've done in Australia, Simon Ross's work in the US, and also work that's been done in Canada. There's a number of studies now that have specifically focused on gay and bisexual men and how do they experience the sexual changes after prostate cancer. Are they different from straight men? And why are there any differences if there are? And what there is consistent evidence is that gay and bisexual men are actually more distressed, they're more bothered. People often use the term sexual bother. They're more bothered by the sexual changes that happen, and they can be changes in erectile functioning. So some men lose erectile functioning completely after prostate cancer treatment. Some men can't get as firm an erection as they could previously. Some men lose the ability to ejaculate semen after prostate cancer treatment, and some men urinate during orgasm or during sexual activity. So these are kind of the key sexual changes that are a source of bother for men after prostate cancer. Now, what we know is that what's interestingly is actually in a number of studies, gay and bisexual men actually report higher sexual functioning, which means that they're more likely to be able to gain and maintain an erection after prostate cancer. And one of the reasons I would suggest that is they're more likely to actually engage in forms of sexual rehabilitation. So we found in our research that the gay and bisexual men compared to heterosexual men were more likely to have counselling to do something about sexual changes. They were more likely to try medical interventions such as taking Viagra or having penile injections, using penile pumps. And they were also more likely to talk to their partner about the sexual changes. So paradoxically, we've got a situation where the gay and bisexual men are more concerned about sexual changes, more bothered, more distressed by them, but they're actually reporting higher functioning because they're doing something about it. Now, you could say that's because they're bothered, they're doing something about it. But I think it's also the impact of those sexual changes on what it means to be a gay man or a bisexual man. And we, in our research, we both surveyed and interviewed quite large groups of gay and bisexual men who reported sexual changes after cancer. And what we found is that many of the men said that they felt that their identity as a gay man or a man who had sex with men was really challenged by prostate cancer sexual changes, that they felt that they were no longer able to fit in with the gay community, that they felt that their value, their sense of self as a gay man was really challenged. Now, we know that straight men can report their sense of masculinity is challenged, so what it means to be a man. But what we have, I would say, with the gay men is it's like a kind of double jeopardy happening. They can be challenged as a man, but also as a gay man, as somebody who's a member of the gay community. Another sexual change that many men report, which is not often reported in the general sex and cancer literature, is shortened penis size after prostate cancer treatment. And many of the men we interviewed said this was really very challenging for them in terms of their relationships, who they saw themselves, being able to engage with new sexual partners, and that really it was very devastating. And it's really not something that's been talked about, that whether straight men find it distressing or they just don't report it to the clinicians, it's really not there in the literature.
Yeah, and within this Malecare support group system, um, easily since like somewhere in the early 2000s, maybe even 1999. We started, well, actually, since photography became a mobile phone thing, uh, we've told men to measure their penises and photograph prior to treatment and then after, so they have a more concrete understanding
Mm,
of what changes have occurred. You know, one of the deficits for men is to sort of accurately report what's going on for them. So a 6-inch penis prior to treatment becomes a 2-inch penis afterwards, or something to that effect, when in reality, perhaps a half inch to an inch was, you know, has been shortened and girth perhaps has been affected as well. You know, we've also find that men are led into helping each other. Gay men are led into helping each other as a consequence of conversations like, I don't know if I'm a gay man anymore, you know,
mm,
or I don't know if I could go out anymore, you know,
mm,
go to a club or a party or a bar or just, you know, a movie or just wherever I enjoy meeting other men. Uh, and once those conversations begin, and usually they're initiated within a safe zone, which is, you know, the support group network that we have. They, you know, whether it's in Waco, Texas, Los Angeles, or New York, doesn't matter. If this is a global kind of conversation, once that conversation begins, then there's an opportunity to find somebody to play with to sort of help you sort of get going again. Um, Before we move on to other, let's stick with this for a bit. What have you learned about men who just have an inability to have a firm enough erection to be anally insertive and now are faced with the idea, am I now going to be a bottom and will I ever enjoy that?
well, what we found actually was that for some men that's devastating, that if they're unable to gain a firm enough erection. um, but many men actually found other ways of having sexual pleasure or playing, as you describe it, found other ways of exploring intimacy. Some men did that by using injections, but a lot of men we talked to said they just didn't like the idea of it, or they found it painful, or it didn't work for them, or they had an erection that stayed for so long it was just awful, and it was really quite difficult. So we had lots of accounts of men who describe what I would say is renegotiating sex, finding other ways of having sex. So one man we talked to who gave us an incredibly rich account of how he now does massage. He actually engages in sex with younger men that he didn't do before, and he's kind of in a sense, changed his whole sort of sense of who he is as a sexual being. Some men did say that they became bottoms rather than tops, but we didn't find that a lot in our research, actually. It was more about finding other ways of having pleasure, other ways of being intimate. Some men talked about widening their relationship. So they might have been in a monogamous relationship with their partner, so they have another partner in the relationship and they were okay about that with their partner engaging in that. Just finding other ways of being intimate. And I think that that's one of the things actually that gay and bisexual men can teach heterosexual men with prostate cancer, is the level of inventiveness, the level of ability to talk about it, as you say, connecting with others, not feeling ashamed to talk about sexual changes. I think we know there's a lot of shame about what's described as sexual dysfunction. And I really don't like that term dysfunction, because it implies that sex is just about a penis operating. And there's much more to sex than that. And I think that's what we see with gay men, that they were doing, many gay men were doing, have much more inventive sex lives anyway before cancer than possibly their heterosexual counterparts. And that continues into the post-cancer journey.
Yeah.
So I think it's about learning to live with those changes, being able to discuss those changes, and finding other ways of having pleasure. But I also think it's really important to acknowledge the sense of loss that many men feel, and not to diminish that and to say, oh, you can't get an erection anymore, or you can't ejaculate anymore, and that, you know, find other ways of having pleasure. That's kind of can be quite what I would say is a biographical disruption. It's actually changing who you are, changing your sense of self, and that can be quite stressful. So I think we do need to acknowledge that. But having support through that journey is important, whether that's talking to other men, and that's probably the best form of support, which is why Malecare is such an amazing network. but also sometimes talking to healthcare professionals or clinicians who might be able to offer ways of moving forward.
Yeah, and the shame part, sometimes it's misconstrued, and I only know this from anecdotes. But sometimes men who are sort of reporting, ticking off boxes that say, are you experiencing a, I don't know how it's verbalized, but a sense of shame or some construct around that. What they really are, if you spend an extra 10 minutes with them, it's a sadness that they're
Mm,
experiencing. I mean, almost like a crying, a
mm,
tearfulness,
mm,
which rhymes with loss, which is, uh, the idea of feeling sad and crying just as if your loved one died or something horrible in the world happened, as seems to be happening so recently. The idea of finding a space to feel safe and sad in
mm,
is a difficult challenge for any man or woman or anyone really, across any disease state. But I think around prostate cancer, there's that added thing because there's an identity aspect of it as well.
mm,
Um, the idea of feeling like you have to connect with other people. Many men live alone and lead solitary lives, will never have a partner, never have had a partner, and and have come to grow accustomed to that. What have you learned about those men who are post-treatment prostate cancer?
Um, I think for many men who don't have an ongoing partner do have casual partners, and that's much more common in gay and bisexual men than it is in heterosexual men. And I think that needs to be acknowledged by healthcare practitioners, and the context of how sex can be different. If the person you're having intimacy with or having sex with is a new person each time, you have to explain to them how your body might have changed. You have to explain to them that you might not be able to get an erection or that you might not ejaculate, but that doesn't mean that you're not enjoying sex. And I think that that's where it's different for gay men and for straight men, because in a sense, each sexual encounter, you're having to do that explanation. And some men talk to us and said, when they tell a prospective partner that they'd had cancer, or they tell them how their body might be different because of that, sometimes the guy wasn't interested, and that's actually quite distressing. I think for other men, as you say, they might not have contact with anybody, and that can be very isolating. And we know that from our research, excuse me, we found that gay men are less likely to be, only in the prostate cancer study we did, only 40% of the men in that study were in ongoing relationships compared to 90% of the heterosexual men. And some of those men who weren't in relationships said that they felt very lonely and that they were because they'd stopped going out, because they were fearful about explaining what was happening to them to a new partner, they were becoming very isolated. And I think that can be very distressing for people, that they're dealing with the loss of connection as well as the loss of what their bodies were able to do. And I think that's where it's actually important to connect with others. And it might not necessarily be connecting on a sexual way, but finding other ways of connecting. We did find that many men in our research did that. So they talked about finding value in other things after the sexual changes because of cancer. So developing other relationships. I mean, interestingly, in the current study we're doing, a lot of people talk about their pets. They talk about actually their connection with their pets, with their dogs. And in the present study we're doing, we've actually asked people to take photographs of their experience of cancer survivorship as an LGBTQI person. And we've had so many people take photographs of their pets and their dogs in particular, and to say that they're, finding connection in other ways.
Yeah, I mean, trans species relationships can be really quite profitable in terms of emotional support and content even, and just to be able to have conversation with another living creature, even though I mean, if you really get down to it, the dog doesn't really know what's going on, in a deep sense, but they do have an emotional connection with you, that transcends any sort of language understanding, beyond. it's time to eat, or let's go for a walk, or
Mm.
whatever dogs really look forward to, you know, and you could ask your dog floating around there, what they're looking. I should ask, you want to go for a walk and see if it jumps into your lap or so. But
I don't know where my dog is. Oh,
uh,
he's by the door. Prostate, come. He's looking at me. He's
yeah. Okay. So the idea of connected with other men and getting support with other men. Let's talk a bit about what you've learned about healthcare providers, doctors, and gay men, um, because everyone relies on their doctor for help. You know, what are what's the difference for gay bisexual men around getting care from a doctor around prostate cancer?
okay. So we've interviewed and surveyed gay and bisexual men, and we've also interviewed and surveyed healthcare professionals about working with both gay and bisexual men and the broader LGBTQI population. And what we found is that basically healthcare practitioners in the main lack confidence and knowledge in terms of working with um, LGBTQI people. And specifically, they have least knowledge about transgender and intersex people. So what we found in our research, and there have been a number of other studies in the US that I'm sure you'll be talking to other people about this, what's kind of we're finding across the board is that a lot of healthcare professionals working in cancer want to be able to offer what I describe as culturally competent care, so LGBTQI inclusive care, where they can acknowledge the needs, potentially the differences, and address the specific concerns of gay and bisexual men with prostate cancer, as well as lesbian, trans, and other people with cancer. So they want to be able to do that. But a lot say they don't have the confidence in how to do it, they don't have the knowledge, and there's a real absence of education. And what we found in our research is that many healthcare professionals say, well, I don't think this, another group say it's not important to men to know about whether someone's gay or bisexual. I treat every person the same. But actually what that means is for the patient and their partner, that can lead to a lot of anxiety about, can I disclose to this clinician? Are they going to discriminate against me? Are they going to treat me differently because I'm gay? And some of the gay men said to us, I don't know if my doctor would be happy to see me die because they might be religious and they don't agree with someone being gay. And that's shocking to see accounts of that. So if healthcare professionals treat all people the same and don't ask about sexuality and don't ask about gender identity, what it means is many people don't come out, so they don't disclose their sexuality, or because they're really fearful, or if they do come out, there's a potential risk that they might experience hostility and negative reaction. And we've had a lot of accounts from gay and bisexual men with cancer who talk about the doctor actually ignoring the fact they said that they were gay, making dismissive comments, sometimes being very hostile when they came out. And that this is a real source of distress. And the other side of it, you could say, well, okay, don't come out, and then you're in a position of safety. But what that means is that your partner's then invisible, you're being treated as if you're straight when you're not, which makes you feel invisible, and you're not getting specific information which is relevant to your life, to your sex life, to your concerns. So what we really need is we need healthcare professionals to be inclusive of queer people, of trans people, to actually ask about sexual identity, to not assume people are straight, to not assume everyone's cisgender, and actually make sure that they give information that's appropriate for that person and that they're positive and inclusive when someone does disclose. And what we've found in our research is that when that happens, the patient and their carer feel much more satisfied with care, they've got much lower distress, they're more likely to be able to have a conversation about what's happening for them in their body, what's happening in their relationship, and they're more likely to be able to access appropriate information and support.
Yeah. One of our speakers, Sean Collins, who's a radiation oncologist in Georgetown in the United States, Georgetown Medical Center, uh, did a Twitter survey uh, a week or two ago, uh, knowing that he would be part of our conference, asking his doctor friends, would you ask, do you do you ask your prostate cancer patients if they enjoy sex with or if they enjoy sex with other men, women, or both? And long story short, out of I think nearly 200 MDs, 77% wrote that they do not ask their patients anything that
mm,
might reveal whether or not they were LGBTQI
mm,
or whatever. They just and many wrote comments saying, "I think it's an intrusion. I don't want to embarrass them. I don't, and all these nonsensical things, including what I find the most vile comment any doctor could say is that I treat all my patients equally."
mm.
You know, um, and vile because it means they're treating them like white middle class straight
Yeah,
patients. Um, it's extraordinary. This is 2022, and doctors
yeah.
are just won't ask.
And I think that's, that Twitter survey reflects the findings that we've had in our research, and that even the clinicians who say, yes, I think this is important, don't ask. And I think that people say, I don't have the language to ask. Yeah, I don't want to embarrass people. Or they might ask specific people that they think look gay. And that's so nonsensical, as if you can tell somebody's gay or trans just by looking at them. You can't. And it's and for younger people, they'd say, oh, I couldn't ask a younger person because they might have their parent there, and that might cause an issue. So it's almost like there's all these excuses for why the clinicians don't do it. On the positive side, though, because I don't want this to be kind of a depressing conversation, I have been really heartened by the interest in our research from mainstream cancer contexts. So I've been invited to present we have a conference every year in Australia by COSA, which is a big cancer conference. I've been invited to do a plenary at this conference talking about LGBTQI cancer. There's a national radiology conference happening in New Zealand in August, and I've been invited to do a keynote there. I gave a keynote at the adolescent and young adult oncology conference by Zoom in the UK. Now, I'm not big noting myself here. This is actually about the research topic.
Yeah.
I think there's a real interest in this area from mainstream cancer organizations. And in fact, it was in 2017 that the American Society of Oncology actually said we really need to look at LGBTQI cancer. We need more research in this sphere. We need to address this population. So those individual clinicians, those 77% in the Twitter feed, they need to get on board with what the cancer organisations are doing. And I think, we're working with the Cancer Institute in our state of New South Wales in Australia. They're running out LGBTQI inclusive training for all of the cancer organisations. And we're working with ACON, which is one of our partner organisations, to drawing on our research findings to do that. So I think this is, whilst on the one hand, you might say, oh, these findings are depressing. We've got high distress. We've got people's needs not being met. We've got, clinicians who say, I don't need to ask about it. On the other hand, I think there's a wave of interest and a wave of research coming that I'm really happy to be part of with your other speakers, saying this is a really important issue and we need to address the needs of this population and we can do things better.
Yeah. And you're absolutely right. There are more opportunities for you, me, and our colleagues to speak, not just Pride and prostate cancer and Malecare. Um, I mean, we've both come along. I mean, you and I met in Montreal like 20 years ago. I was giving what probably was the first presentation at the Union of International Cancers, something or other, Congress on LGBT cancer survivorship stuff. And, more often than I'd like to think, I've probably been the first in that period of time to present on anything, like at ASCO, at a couple others. But so now I'll allow me to depress our audience a bit. All of this is great. All of the opportunities for LGBT competence building and cultural literacy and this and that is great. But it boils down to the 77% of doctors who, hear all this, maybe even take a continuing education unit on an LGBT thing. But in practice, they're still not going to ask. In practice, they're not comfortable. In practice, they're scared of the answers that may come out if they ask, because they don't know what to do with those answers. And it's sort of like Moses taking the Israelites through the desert. You got to kill off a generation or two before you could start anew. And my fear, and I'm basing it on my experience with talking to MDs and doing grand round things, every now, presentation things every now and then. I mean, people are people, and you could teach people also. I mean, you could teach anti people who are afraid of vaccinations that COVID vaccinations are good, and there's going to be 30 to 40 to 50% of a population that resists getting vaccinated. You could teach X, Y, or Z, and people, will hear it, get good grades on those exams or whatever, but they're still people, and we have to deal with people and the emotional burdens that they had since childhood. And part of those burdens impact, people whose care they hope to impart. And so unfortunately, I have a deeper and darker expectation from the world than you and probably most people do. But I see it repeated in our support groups, and it's tear inducing in me. Yeah, go ahead.
I think we need to change at the policy level. We need sexuality and gender identity, which includes trans identity, to be on all intake forms so that
Yes.
people can say. I think that's the first thing. We need to collect data on sexuality and gender minority groups in cancer registries, which they're not. I mean, certainly not in Australia. So when they, count whether someone has cancer or not, they don't ask they don't ask about sexual orientation. They don't ask if they're trans or non-binary. So we need that data in the first place. And we need to train medical practitioners. This needs to be an issue in medical training so that people are taught how to do it. But I agree with you. That doesn't mean that the individual clinician's going to ask, because they're still dealing with their own embarrassment. People don't like talking about sex anyway. So talking about gay sex is like freaking them out even more. Like they don't want to talk about straight sex, and that might be what they do themselves. And actually it was interesting in our research that even the clinicians who identified as gay or lesbian were not asking, which is crazy. I was really surprised at that. But I would say that, maybe I'm being a glass half full person today. With a lot of the people who are identify themselves as gay or bisexual, when they come out, I would say increasingly they're getting a positive response from clinicians. So I think it's about saying to people, disclose, come out, do it in a way that you feel happy about. So do it by saying, this is my partner, this is my husband, so that you're actually coming out in that way. You don't have to say, I'm gay. It's bringing your husband, or ringing up beforehand and saying, like, I'm a gay man. Is this a safe space to come? So checking out your clinicians if you're able to have an option about who you go to. So actually, I think we as a LGBTQI community need to also be outing ourselves and making our clinicians accept us. And I think it's interesting that particularly the older people in our research, who took that attitude. That's how I am in my own. I have a wife, and when I go to the doctor, if it's appropriate, like my doctor always knows I've got a wife, I've never had any problems in terms of healthcare. Now, I'm not putting the issue there, the onus on the person, because you could say I've been lucky, because there are negative experiences. But I think what we found is in our research that people who are out, who are able to be confident in being out, and particularly those with partners, it's much easier if you've got a partner, that actually, with most clinicians, will actually deal positively with you, will actually accept you. And if they don't, try and find another clinician, or you can make a complaint. We shouldn't be tolerating homophobia and transphobia in the health system. And I think if the clinicians won't change, we need to actually have a voice together and actually say, we're not putting up with this. It's not acceptable.
Dr. Ussher, I think that's a good place for us to close out our conversation. Call to action for everyone to sort of to be out to your doctor. at the very least to save your life and increase your opportunity to live a longer and happier life. Thank you for your 20 plus years of investigation and research, and for writing papers that are absolutely seminal to our field and are read by thousands of physicians and nurses and social workers like myself and others, and that a social worker like myself can fully understand your papers on a first read. That's also helpful too. But I think the most useful thing about your work is that it's useful, and I'm grateful to know you, and grateful uh, for all the efforts that you've put in with you and your team to help us live longer and happier lives with better information and data to support it. So thank you for being part of our conference, and welcome to Mailcare's faculty.
Well, thank you, Daryl, and also thank you for all of the work you're doing in Malecare. As you say, you're a pioneer in this field, and I think your voice and the work you do in Malecare is essential in creating this network. So thank you very much, and I look forward to writing more papers that hopefully you will continue to be able to understand.
Thank you, and thank you for those kind words. Okay, um, see you around.
Okay, bye. See you. Thank you.